Hey y'all, and welcome back to the latest episode of Code Brew. I'm Joe King, and I'm here with my co-host, Lukewarm.
Hey everybody, it's Lukewarm.
And we are back for episode 9, and it's a really special episode for us. We've got our first guest. It's crazy. We finally made it here. We've talked about this moment for a while. So with us today, we've got Norma Saline. Yes, Norma Saline. That is her name. It's her real name, I swear. And she's here with us. We're talking about ICU nursing. So, Norma is. We'll say hello, Norma.
Hello, everyone.
You sound young.
I am so young. Been a nurse for 22 years, but I don't show it.
Oh yeah, fair.
She's very young for Norma. It's a generation.
It's a generational name. It's family name.
Family
name. No, so yeah, we're really excited. So she's got a good background in ICU nursing, and that's why we're here. We've decided our next series, or at least the topic direction, is different types of nursing. So yeah, I mean, today we're gonna do kind of an overview of ICU nursing, and then in the coming weeks, you're gonna see us dive deeper into the different types of ICUs, like differentiate between CVICU, neuro ICU, trauma ICU, surgical, what have you. And with that in mind, we are looking for some more guests. I would love to, I'm just going to shamelessly plug, we do need some guests for some different types of ICU nursing. I specifically like pediatric ICU, neonatal ICU, because those are things that I do not do. None of us do here where we currently are, and I'm hoping I have some friends or we have some of our loyal fans that part of the Code Brew family brew crew.
Oh my God.
Some of the brew crew that might want to come and talk to us about their type of nursing. So, and I mean, if you're not ICU, don't worry, we're gonna get to you too. I mean, I have so many different things I want to talk about. So. But yeah, so Norma's here. She's gonna introduce herself really first and kind of tell us about her background.
Hey, everybody. Like I said, I've been a nurse for 22 years. The majority of that spent in critical care, and also floating between intermediate and critical care. Spent some time with pre-op anesthesia as well. Worked day shift, night shift, part-time, full-time. Seen it all. A couple different facilities. And have lots of experience.
Awesome. So she's, pretty uniquely qualified to talk about ICU nursing in general, and also just kind of like that good overview, because she kind of bounces around to a lot of different types of ICU. So we're really excited about that. Of course, Robert is here. Of course, Luke is here, and he is very, he's done a lot of time in ICU, right?
I also get around. Yeah,
he gets around. He gets around all right.
So backgrounds and floating here between our cardiac units, surgical transplant, CVICU, rapid response team. I don't know, all of those fun areas. No PACU, no OR, none of that. But
we'll get to those. They'll have their day. This is a day for me to, well, quite frankly, keep my mouth shut. So yeah, with my background in the ED, I am not gonna have a lot to say, but I'm gonna try to keep us, on track like I always do. So, no, we're really excited to have our first guest. How does it feel to be our first victim? I mean, guest.
I'm excited. I'm excited for you guys. I think this is a great platform, especially for new nurses, the younger generation. Podcasts are huge. And it's information that you don't get in school, and you might not necessarily get from every preceptor you have either. I think it's good information to have from different views.
Awesome. We're excited. Been planning for this day for a while, so I was super excited when I woke up this morning. Okay, as always, we will go over our disclaimer really quick. The views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only. It should not be considered medical advice. And while we're, hitting the housekeeping tidbits, I will do another shameless plug for our merch store. we would love for you to check out the Code Brew merch store at codebrewpodcast.myshopify.com. I'm really excited to see you like walking around with a, water bottle or a t-shirt or something with Code Brew on it. And, yeah, I think it's pretty cool. So I've got a few things. I've, passed out a few things, and I think the quality is pretty good. So anyways, shameless plug over. So let's get on with it. What is ICU nursing? And let's just start.
Yeah, I'm interested. Like, I don't think I've ever really I know what it is in my head, right? But I'm interested in what do you say ICU nursing is? Because I guess
care.
Yeah, but I'm always, I don't know.
Yeah.
Well, I'm talking to students frequently about what it is, or people that are interested in going to it. But I don't think I've ever been this what's the definition of ICU nursing?
But there's clearly a difference between somebody who's an intermediate or med-surg level. Yes, something can always happen in a patient that's strictly ICU, that is that sick, the acuity is that high. You have to have great critical thinking skills. You have to be a step ahead sometimes of even the physicians, because you're with that patient for 12 hours. You need to be the one who notices any change, a significant drop in pressure, a drop in urine output, whatever it is, because it has to come from you, and it is significantly harder on that patient than somebody who's med surg, who might be able to, we can maybe fix whatever that little thing is.
Or maybe making a little bit of urine, on their own. So, when I think about it, I think about people go there for rest devices. When I am talking to people about it, I'm hey, we can put you on CRT and we can rest your kidneys, and then maybe we can wean that, and your kidneys can pick back up again. So we can put you on a vent, so that's what we're going to most commonly see, so a patient's on a vent, respiratory distress, whatnot. We can clear that infection or the fluid or whatever it was that was compromising your breathing. And then we can wean you from that. So, the same thing with the heart and cardiac assist devices, your balloon pump, Impella, whatever it is, or ECMO if you're really, really, really sick, where we're resting both, potentially the heart and the lungs. Mm-hmm. So, I look at it as rest, but why, when we have these, so let's say there's 5 patient ratios in other areas, and then, you're at a 1 and 2 patient ratio in the ICU, or that's what you're going to frequently see. A lot of that has to do with hemodynamics. So what is that? For someone that doesn't work in the ICU, what, someone's hemodynamically unstable. Why do we need to have them on that reduced capacity team?
So you could notice, because they need closer monitoring. Something, if they're already unstable, you need to be able to say to notice if things change.
Yeah. So because we're frequently monitoring. So minimum standard of care, we'd say vital signs is our vital signs are Q1 hour, so hourly. And I would always say that best or very good practice is going to be an arterial line. And I think sometimes when I'm talking to students, they don't necessarily get that. I'm why would we want to know their blood pressure every second? And I kind of have to explain it as even if we were taking it every half hour and it was a non-invasive blood pressure and it's at 120/80 right now, and then a half hour later it says 50/20, how long has it been? 50/20, so
29 minutes.
Yeah, 29 minutes. Well, 1 minute, 29 minutes. We don't know, but we do know 20 to 30 minutes in a hypoperfused state.
Sure.
We're going to have organ damage, and someone that already probably has organ damage, because we know sepsis is the number one killer. We know that is going to deal with a hypoperfused state, and can ultimately end in organ damage due to that lack of perfusion. So, it's just interesting to think it through. So we're on a lot of really strong medicines, and seeing somebody's blood pressure continuously or having that closer monitoring allows us to intervene a lot faster. On floor, like, outside of the ICU, like people's blood pressures are more stable, and, maybe we treat systolic blood pressure over 160 and it's 165, and, it takes somebody 15 minutes to tell me that, like, that's okay.
Right.
Like they're going to make it. This, 50 over 20.
They're not, yeah.
We got some beeping that's going on. We need to be in there. Like, I don't need to go down 2 hallways and to the left and, pull a medicine. Like, they're probably already on a drip that we're going to titrate up. So yeah, so like these patients, so a lot of them are going to be on pressors. So we're like increasing their blood pressure. Some of them are decreasing their blood pressure, because it's too high. More often than not, I feel like we're
usually raising.
I feel like we're on the up, but everyone's always see like the nicardipine, whatever.
Rarely we're lowering.
Yeah, but it's I always find it weird when we're lowering. I'm like, oh,
you feel comfortable. You know what to do.
Well, it's just it's like you're so used to
want to go.
Right.
I always, I'm like, I need that math of 65. I need that math of 65
or 85. The GI team here now.
Oh, okay. Yeah, so that's probably a thing with our liver patient. Yeah. So always provider specific, but frequently, and for the NCLEX, I think you'll probably see.
Yeah, I don't want
60,
65.
65. Some teachers teach 60. They still actually say, I think 30 cc's of urine an hour. Like rather than considering like, okay, well, the patient's got 4 liters of fluids going in them every hour from all these pressors that we have them on. Is 30 cc's enough? And that goes, that goes to the critical thinking, because, you can say, well, they've got their 30 cc's an hour, and it's like
X amount.
It's like, okay, but I'm putting like a liter of fluid into them every hour. So like, if so in a shift, I put 12 liters in them, and then they had 360 mils of pee.
Really,
we're plus 24 pounds. We know that's in their lungs, right? Like we've gone from 40% on the vent to 100% on the vent. Yeah. Like there's, it's got to come out somehow.
But you're right. That does come with critical thinking and being in a clinical setting and understanding that.
Yeah, one thing that like really helped me was, I started on the floor at a non-ICU unit. Reading those provider notes, like where it would say like GI, like what it is that we're doing, cardiac, what it is that we're doing. So I could understand that. In the ICU, I mean, there's rounding, and you're talking over every system, and then that's helpful. Your providers are more available to talk through stuff. I mean, what somebody told me the other day, it's like, oh, why aren't we giving this patient Librium? It's like they're like detoxing. And they're like, well, we don't use Librium at liver patients. And I was like, detoxing, like, isn't that all liver patients? Like, apparently we use phenobarbital. But I was like, is this new? Like, is this new? And we should always be researching. We should always be looking, but
that's how
I'm used to Librium. I still have questions about it. I've got something to look up. Yeah. It's like, when did this come about?
I did actually have a patient on phenobarbital the other day.
Yeah. Mm-hmm. So it's a thing. Yeah. We're going to see more and more of it, I guess.
Well, that's the thing about nursing. There's always new research. There's always new, even though that's not a new drug, always new drugs.
In fact, it's like a really old drug. Yeah.
Even if you've been a nurse, you still have to ask questions.
Well, if we didn't learn to make things better, we'd still be using, leeches.
Leeches, yeah.
Oh, Typhoid Mary.
Yeah.
Oh, gosh. I was watching a show about her the other day. Was that? No, Drunk History.
Drunk History?
Typhoid Mary. Yeah, there's an episode. It's pretty good. Preferred.
Some of the things that I thought it'd be cool to mention, though, is like some of the differences in the settings. I mean, I think one of the advantages you have in ICU is the ratios. Obviously, you are able to spend so much more time at the bedside because of the ratios, but also
well, you live in the room.
Yeah, you basically do
a lot of the times. Yeah. I mean,
but you also have a doctor right there.
Yes.
I mean,
or an advanced practice provider. Yeah.
You have a provider typically right there in the unit. So when things,
and a pharmacist.
Yeah. My favorites.
And respiratory therapy.
You have
all the resources you generally need in the unit, which is very nice, especially when you have
And help
a question
Yeah.
or, or something doesn't look right or, whatever it might be.
Much more of a team than maybe sometimes you have in a mixed acute or med-surg intermediate level of care. So I think that's cool. But I think some of the other things that drive like ICU, for me, a notable thing is like there are policies, that say you cannot give some things outside of the ICU. So like some of these people are getting admitted, because they need closer monitoring, but it's also because they need like certain medications or certain therapies that cannot occur outside of the ICU.
And shouldn't occur outside.
Well, and a lot of times, so like, assessments that are Q1 hour, like that can't happen on a 4 or 5 patient. First said outside of comfort care, we're not going to utilize that.
Most forms of sedation outside of comfort care, right? Those pressures that we talk about, I mean, they just generally don't happen outside the ICU.
It's not titratable.
Yeah.
Right. Yes.
Which I think.
But in most places, they don't happen outside the ICU. Yeah. We have like, one unit where we do some things, but even that's pretty, I mean, ours is just kind of a special case. So like, yeah.
Yeah, I've never worked where we could have LevaFed outside of an ICU.
Right. So, but yes, I mean, that's something that we do here. But no, I think you have touched on some great points. So with those things in mind, is there anything you want to?
Oh, I think I would just like say that, like these patients, so they're sick, like they're here with an infection or high propensity to get an infection. And, I would just say, while it's those central lines help us a lot and those Foleys help us a lot because we want to know about urine output and we want to know renal function. We want to have access, to get labs and to give our medicines, and people are intubated. Just knowing that all of those are sources of infection and really like, I would say another reason for, I don't know if it's necessarily like making these patients in the reduced ratio, but understanding the importance of like those bundles, like CLAPSI bundle, CODI bundle, those nurse-driven protocols, the ventilator bundle. Your subglottic suction is so important to be able to get those secretions out of the cuff, so they don't go down in the patient's lung and cause pneumonia. I mean,
if you're diligent about all of the things you're supposed to do around dressing changes and peri-care and all those things, it just becomes routine. When you go and you do your assessment, you do all of the things. You have to start doing those things in your routine. You have to do them. You have to do the oral care, all of the things to prevent those kind of infections. But you just put it.
But just like understanding the importance of it, because like I work in some places where like that's part of like the checklist with interdisciplinary rounding, so it's everybody's on page with it, and everyone is like holding each other accountable. It's like, oh, you've got your proton pump inhibitor, your head at bed, your SCDs, subglottic suction, oral care,
to help your patient already compromised, who's already sick. Why any reason for something else when you can do things to prevent it?
Yeah. So and some of that's going to come from precepting, some of that's going to come from culture, but just when we think about those sepsis rates, I'm going to talk about it time and time again. It's every hour of delayed treatment for sepsis, which these people are probably already being treated for sepsis, but every hour of delayed treatment is like 7.4% increase in chance of mortality based on what they're here for. So in a 12-hour shift, if we don't notice it or we're doing something that's like driving one of these infectious processes, when they trigger, we've delayed care potentially up to 12 hours, which is, like 100% chance increase in mortality. So I just think it's really important to always harp on those measures and peer review, whatever it is, but, make sure that you're working in a culture that really understands the importance of those things and discusses them.
Oh, yeah, for sure. So what do you feel like makes a good ICU nurse?
I personally think a nurse who can be realistic about what they know, what they don't know, what they're strong at, and can ask questions. I tell the clinical groups that always ask questions. And it might be a dumb question. There are days you're going to ask dumb questions, but it'll save you from a mistake. It'll teach you something. And I think ICU nurses need to be realistic about also what's going on with their patient, because a lot of times you will be the person between the patient and the family. I think most physicians don't do a very good job. They come in, they put their 2 cents in, and then they walk out. And if you're a kidney, you come in, oh, the kidneys look better. Okay, well, your liver looks worse, or your lungs aren't healing. And sometimes you have to be the person to put all that together.
You'll see it like in every hospital system where, like the pulmonologist comes in, it's like your lungs are shot, they're never going to get better. The GI doctor comes in, your liver, it's never going to get better. Kidney doctor comes in, you're never going to get better. And then the podiatrist comes in and he's like, your toenail looks good. And the family's like,
they hold on to that.
They said mom's fine.
Yeah, they hold on to that.
And you're
because they just don't.
Who said mom's fine? Well, that's what they want to grasp.
Right.
You want to grasp the provider to provider communication, really understanding the plan of care, and being on the same page with what, having a general message that we're giving the family, so they don't have mixed messages, or a mixed understanding. And, there's different people all the time here from families that, the son hears one thing, the daughter hears something else from another provider, and they're trying to put it together and they don't speak medicine, so that can get confusing.
But I do think good ICU nurses and you also have to be willing to learn. You have to be ready as well for rounds. And if you see something,
I've run in that room so quick. If I think somebody's about to round without me, I mean, even on the floor, I run in that room so quick.
You have people on the unit who day to day, they just kind of maintain. Okay, well, they've maintained on this ventilator settings. They've done, but something has changed in, the 12 hours of night shift that told you, hey, this is different. You need to be prepared to say that because, if you're the one that's with the patient and all of a sudden after 3 days, somebody's kind of been holding their own. Now, one little thing is different. It could trigger something new.
Yeah. Well, and I think it's important what you said, like knowing that you can, you have to be in an environment where questions are encouraged.
Absolutely.
I mean, I
thinking. Yeah. You have to.
I ask stuff, and I want to be able to ask questions. Sometimes I ask questions when I know the answer. Like if I'm precepting, because I want I want my student or I want my orientee to feel like this is, it's normal. Like everybody asks questions. And I'll always explain it as doctors can consult other doctors when they don't know something. Nurses should be able to do the same thing.
For sure.
Very true.
So you're not expected to know it all, but
you work everywhere.
You're expected to get...
never taking care of transplants. Like the ICUs I had worked in, we didn't do transplants at the previous hospital. So I had a lot of questions when I started working on the surgical ICU and on their transplant floors. Sure, you learn it in school, you hear about it, some of these drugs, but it's a different environment when you're in
actual practice.
When you're in a facility that actually knows transplant. So that was, and I had no shame in asking, why do you do this? What is this?
Well, it shows you care. It shows you care. Right? And if someone's, if you're in an environment that doesn't encourage questions, run.
No, we've definitely discussed that many times. But I mean, I think that is even more important in the ICU whenever your patients are critical. I mean, there's no place for egos. Even though we all tend to have an ego,
sure,
in this business, right? But there's no place for it really in the ICU. If it gets in between, your patient and providing good care. And so open communication in this environment is critical. So,
I think it helps the new people too feel like they can ask a question. Right. You always hear nurses eat their young, blah, blah, blah.
Yeah, I hate that.
I hate that too. And you used to have so many years of med-surg experience till you could go to an ICU. That's not really hasn't been the case for a long time, just because we need the bodies and the shortage. So having very smart new nurses coming in, they know the material, they know the content, but being able to apply it to an actual patient and feel like they can ask a question on, maybe they haven't seen a specific kind of NG tube or Dopphoff or things you just don't see all the time, and so being able to
learn.
Mm-hmm.
I mean, we can help them grow,
right?
and show them the way, as long as they're eager to learn and open to constructive criticism. And so,
well, and extern programs and like, the extern programs, like if you're in the ICU, they're trying to pull you in there as well for capstone. And then you have a 6-month orientation. So, they're at least in front loading that education a lot better on the staff. But I used to have to be recruited to go to the ICU. It's a thing. And it was like in my lifetime, and I only have 12 years of experience.
I mean, I started on a med surg floor, and I think it helped me, me personally, with time management. I was able to get my assessment skills down. I knew how to talk to a doctor, and that didn't scare me anymore. Not a lot anyway, but just having a couple of years of just med surg. I had friends that went straight to the unit and did just as well. But for me personally, I think knowing the way, you want to be a nurse or where you're comfortable, and that helped me. It was just.
But if you told you, coming from where you worked on the floor before, so if you were ICU core staff and they were like, we're pulling you to the floor, it would not be the worst day of your life.
Right.
Now, if we pulled someone that has only worked in the ICU to the floor, it would be very difficult for them, even with CAP teams, so they it would be nice for them to better understand. And some of that is because maybe they do a whole lot, and their assessments are so thorough and their engines are so thorough. But we are also capping their team because of that.
You may bring up a good point. We get real cocky. Me being one of the worst ones. Hello, I am the pot and the kettle all in one. But no, I think we need to recognize the strengths that different specialties bring to the table. I mean, our med surg, our mixed acuity staff, they have to be very good at time management because of the sheer volume of the number of tasks that they're having to juggle. Our ICU team, they're better at probably assessments and details and probably
teamwork
thinking. I think teamwork has to be good across the board.
It has to be. And, I tell my students, good nurses are good PCAs. You should learn all of that stuff. You have to count on your PCAs and your fellow nurses to get things done. And, no task is beneath you as a nurse. So if somebody needs help, whatever it is, you need to do it. So
I just think you can't be a good nurse if you don't have a good team to support you. I mean, it has to be, you have to be all in. I mean, I think part of what makes someone a good nurse is their ability to communicate with other members of the team and bring it all together. Because we all know that we're usually the one that's, tying the bow around everything. We're keeping it all together. We're coordinating the care. And that it's like that in the ICU. It's like that wherever you are. So I think it's really important. We don't get so, I hate to say this, but like sometimes elitist, like, oh, I work in the ICU. Like, we're better than other people.
Right.
Or I do this, or I do that, whatever the case. And the ER can be like that. We get real cocky with, we're ER.
I kind of feel like annually people should be required to float to these other areas
just to see what life is like.
To understand it. I mean, like the ED to floor transition, when the floors are asking all these questions, ED's like, that's not a thing.
Yeah.
I mean, like, everybody should have like this shadowing pool experience to like, when you're downgrading a patient,
people spin to their arms
when you're
IVs and ACs.
Yeah.
Why do you do that?
But when you're downgrading a patient from the ICU, like and it's going to a 5-patient team and it's been on a 2-patient team today, and there's 2 that you can downgrade, if you had worked the floor before, you might be like, oh, well, Molly, maybe we shouldn't send Molly out right now. We're only sending 1 patient. Molly probably shouldn't go to a 5-patient team.
Right. True.
We, our jungle gym should stay here, whatever it is. We should send the more appropriate. While they both have downgrade orders, they they probably have 2 different patients, and there's one that since they haven't worked the floor and they don't understand that workflow, symptoms are probably making the decision that's easier for them.
Right. Yeah.
No.
Yeah.
I mean, I get that. I mean, I think.
Do you make those decisions?
Well,
Are you the reason why I got Jungle Jeff?
You are absolutely.
Sometimes. I mean, but
Get this guy out.
it
Fair.
would be really, I think, it would be really helpful if we all knew what it was like in the different areas. I mean, I think it.
Heal the world. I feel like we're about to start doing some kumbaya, y'all, like holding hands.
No.
I mean, the shots have already been fired by Norma. She's mad about all the ACIVs.
It's just ridiculous.
ACIV. It's the biggest thing.
I get that. But then if you have anybody who has any
central line.
No, I just want people to have mobility.
I don't.
You put what? Oh, you're right hand dominant and you have a big IV.
Yeah, I mean, that was the question. It's like, what is your dominant hand? Like when they teach you, so let's stay away from it.
That's that. I would say hold still and hush.
Yeah. They're like, my IV beeped all night. Some idiot ED nurse put you in here's your options. Keep your arm straight or let me stick you again in a much more reasonable way.
Hey,
God.
Okay, y'all are good at critical thinking, ICU, okay? Our mixed acuity med surg intermediate nurses, they're great at time management. The ED nurses know about prioritization, okay? They know.
That's true.
And they can triage. If a disaster comes, they're going to be like, you go over here. We'll talk about triage.
You still all get ACIVs.
Everybody gets ACIVs. Hopefully a 16 or a 14.
14s. But that railroad's
Where's the level 1 infuser?
Oh my God.
Okay, so good ICU nurse. So teamwork, I think. What about emotional resilience? What about coping strategies? I mean, they do see some of our more challenging conditions, right?
And I think if you worked through COVID in a unit, you figured it out. But yeah, I think there are times where I go home and it's a heavier day than other times. I've always found like the younger patients, to me, I have a harder time with younger patients.
Oh my goodness. Why I couldn't work in peds?
No, I know.
Yeah.
I could never do peds. Well, especially having children, peds was never I couldn't do it. Then there's cases that, are just devastating. I mean, there are some medical conditions that are just awful and awful to see families go through. So yeah, I mean, you have to have some a good support group of your own, whether it's nurses, whether it's friends outside, whether it's family, what if it's a dog, whatever it is, just an outlet. Because nursing is sad. It's real sad sometimes.
Yeah, we tried to cook.
I mean, you see some good things, but it is, I think one of the things that was hard for me at first, and now I don't realize it because I am going to so many different places, but when I was like anchored on a unit, like someone would leave and like I don't know what happened to them.
Right.
Like I'm like, did they get better? Like did they, like that was, because you spent such a long, like months with them. And then it's like, oh, what happened?
That happened the other day. I saw with a young patient, and she ended up getting a new set of lungs, and I saw her walking out. She came in for therapy or whatever, and I saw her walking out, and it just was...
So you've seen a transition.
Yes, and it was just so heartwarming. She was so happy and so full of life. Because when I had her in the unit, she was none of those things.
Right.
And had she not gotten lungs when she did...
That's really emotional.
It's very emotional. And she's like a few years younger than me.
But that's the good. That's the good.
That's the good. Yeah. So when you can get those wins...
You hold on.
Yeah.
They should have... These patients should have required follow-up with us. I need a 3-month check-in, a 6-month check-in.
No, I feel the same way. I mean, as an ED, we never know.
Right.
I mean, they're not with us very long. We send them upstairs. We hope, we send them to y'all. We hope you keep them alive, that you get them better. And there's always that one, really, what happened. And you do occasionally, especially when I worked in like trauma, like they would months down the road, maybe even longer, they would come back in because they had like those trauma outreach people and come back in and meet the people who worked on them and stuff. And you'd see those positive. But yeah, I mean, I could think of one guy in particular. I mean, I kind of had one of those moments. he came in, and this was many years ago. This was not even in this current state where I live, but came after a boating accident, and was torn up. I'm talking about like I was walking to the OR, like holding sterile towels,
just to keep them together.
Because some pieces weren't attached the way they were supposed to be, or definitely weren't in the cavity they were supposed to be living in. And, I really thought, this guy's a goner. He was like 16, 17 years old. I was like, he's never going to make it.
Yeah.
Because, boating accident, water, wounds, the infection rate.
Right.
You think about all the
water.
different things, like there's so many reasons why this kid is never going to make it. And now, through the advent of social media, and like his mother made a Facebook page for him, at some point down the road. But he, is married with 2 kids, and, he's living this whole like life. And like, I see something from him, come across my Facebook screen every now and then. I'm like, oh my gosh, like, just so grateful.
It is. It's so good to have those moments too, because you get very, very cynical.
Yes.
When all you see is difficult things, sad cases, you can get hardened.
Yeah.
And nobody understands that unless they're in the midst.
That's a protection
Yeah.
mechanism of us. Like, we also live in Kentucky where, quantity of life is often more important than quality of life. Like, I do think that we have a different perspective of
health literacy and like what
it's like social, like I don't know, like like there's a lot of care that we do that it's not
futile.
So a hard case can really kind of look like 2 things. I think a hard case can be someone who is losing their life too soon, and sometimes a hard case is whenever we are prolonging the life of someone who we should be letting go, like, and they're of advanced age,
right,
or they're of a very advanced disease, or they've suffered a very serious event, meaning that their quality of life is going to be nil. And we can see those things, but sometimes like the health literacy, the education level of the family is such that they want to hold on to the tiniest sliver of
110 comorbidities and 110 years old and full code, all measures. And it's like, oh gosh.
That's another way that when nurses can step in and clearly just listen and educate. You clearly aren't going to tell anybody what they should or shouldn't do with their loved one. But like I said before, most physicians, unless they're a palliative care doctor, but some of these conversations need to have had way before you even consult a goals of care team.
Right.
And as a nurse, you can, listen when they ask questions and use that as an open opportunity to maybe try to explain what's happening. Not ever pressure anybody, clearly, but just if they don't know what they don't know, especially if you're not in healthcare. And if it's somebody who was just out farming last week and now, that's a hard thing to wrap it. Well, they were just dancing or they were just working the day before.
Well, we talk about, last week on the Code Brew episode, we talked about it's not what it looks like on TV. And like, even if they're here in the hospital at the time of an arrest, like their chances of survival to home are only 20 to 25%. And that's in like the best of scenarios. You know what I mean? So it's just not like, we really try to be realistic. And I think providers sometimes aren't able to explain things on the level that people need. I think sometimes nursing is better able to bridge the gap between, like this is in more layman's terms, what reality is.
Mm-hmm.
And it's hard for us to carry that.
But you might have a closer relationship with the family too, because you've been in there all day long and they see the love and care that you're providing.
There are some physicians who very, very do a very good job of talking to the family, but sometimes if they're having that discussion as a nurse, you should go into the room because you're going to
I want to hear it.
That family is not going to hear. It's going to go in one ear and out the other ear because they're in a time of of a really hard emotional time for them. So for you to go in there and hear, so you could reinforce, can answer the questions that all of a sudden now they have when the doctor is already gone. But it's not an easy thing. It's not an easy thing to talk about end of life. It's not an easy thing to go through. Unfortunately, we will all die. We will all have these conversations. But I think understanding the family dynamics too, that's a whole other.
Oh God.
You have people coming out of the woodwork. You could have a whole episode on family dynamics, but
yeah, I mean, we absolutely hate it whenever like somebody's wife and girlfriend and baby mama, and then their mother comes in.
Mm-hmm.
We did not want to know that you had 3 people out there that thought that they were in a relationship with you, and your mom didn't want to know that either.
Right.
You know,
and now you've got your Jerry Springer show,
and you're like whenever and you're completely intubated, and are unable to answer their questions, and they're all devastated for different reasons, and they're all so mad, and that is a wild ride, Mr. Toad.
It is. It's and I also I always ask. I made the mistake one time earlier in my career where I had a very elderly gentleman as a patient and a very young lady sitting at the bedside. I, in all my youth, asked if that was her grandfather. It was her husband.
Oh, no.
You
didn't even go dad.
I didn't even go dad.
Jumped over.
I mean, there was that. That was the age. That was the difference.
What?
It was like Bill Belichick and his girlfriend, and it was just. I thought for sure.
Oh,
for sure.
Oh,
That. So I don't assume anything anymore, and I say, and who am I speaking with, or who is this person to you? Because.
But you learned.
I learned.
You learned, and you're teaching.
Oh, she was not.
You asked her if she was pregnant too?
I did not. That's not.
Oh yeah, that's always good.
I love. Yeah. As a woman,
no assumptions.
No
assumptions.
But yeah, I mean, family dynamics make end of life, any kind of discussion, hard, but definitely end of life.
So if you could, we would just love it. Patients out there, if you could just get your life together before you get,
even if you need to slide us a note. This person's okay. This person shouldn't talk to this person. Just give us a heads up. A little something to go with.
Please don't call this person. Anything, whatever you can do to help us out.
No judgment. Just
it's like whenever you extubate somebody and you know that they're about to find out that all their
women,
lady friends
or men,
I mean, all their mess is about to be put on Front Street whenever they open their eyes. They're like, oh, it's about to be a rough day for you, sir.
Just act like you're asleep. Go back to sleep.
I know, right? No. Okay, so a few scenarios I just wanted to throw at y'all. Well, I mean, nothing too deep. We can just kind of keep it surface level. But, so how do you handle the crashing patient?
You get help. First and foremost, you get help.
Absolutely, that's awesome.
And then you go from there. You get all the hands on deck that you need. You assess. You make sure all your equipment is plugged in.
Yes. Oh, they weren't crashing. They actually weren't crashing.
You look at your patient and get help.
It's funny because people
are gonna jump at it.
Right.
Plug it out and plug it from the wall.
Yeah.
That's not actually how it works. But sometimes, electricity is life.
Yep.
No, yeah. Okay, what about the difficult family member? I mean, we kind of touched on that already.
Yeah.
Like, what about, like, someone who, is just, like, I mean, obviously, it's the worst day of their life, right? Mm-hmm. Their family member is, like, very ill and in the ICU. Like, how do you, like, bridge the gap between, trying to, like, get them under control in a way to where you're having productive conversation, but also have that empathy?
I think sometimes you just have to let them vent, or let them do whatever it is, as long as it's not, violent, but let them just be heard and explain to them, I really want to help you understand. Mm-hmm. I understand this person is important to you. Maybe if you need to take them to somewhere quiet so, they can get all of that out. But just listen. First, start by listening. If it's a safe environment for everybody, listen to what they say. Not how they're saying it. They might be yelling at you and cussing you up one side down the other, and it's not about you.
It's usually, when I feel like whenever people are like, the thing that they're like yelling about is always something different than what they're really mad about. Mm-hmm. So I think like that listening, like really you're going to find out it's like some event from 3 days ago that they're really triggered about.
Here.
Yeah, I'm
real scared.
I'm like, why is she throwing stuff about this applesauce, you know, and then it's like, it's something 3 days ago and, you know, whatever. But yeah, it is these people's worst day of their life. And we need to be understanding of that. We also need to practice in a safe environment.
Right.
So, you know, I think just like listen, hear them, let them know that you've listened, active listening, you know, hey, this is what I heard. This is what I hear you saying. Mm-hmm. It's okay to set limits, you know, I mean, but explaining, we both want the same thing. Like we both want your loved one to get better. You know, while I'm here for you, depending on how much you're needing from me, like if you need me every 5 seconds, you know, it does kind of take away a little bit of the love and care that I can give to your loved one. So like, you know, as long as we're not interrupting care. So listen, I hear you. We're going to make sure that we stay consistent from shift to shift, you know, answer whatever that problem is. You know, I'm not going to pass the buck on it. This is what I'm going to do this shift to make sure this goal is met. And, you know, during bedside shift report, we're going to talk about it again in front of you. We're going to set new goals for that shift.
I feel like
and letting the provider team know.
Complaint I hear a lot, and not just in the ICU, but floating communication in healthcare is lacking. Whether it's
there's always room for
provider to patient, nurse to patient, nurse to family. You know, we have all had the experiences where a doctor will come in first thing in the morning. Oh, you just go home today. Okay, great.
You know, there's 15 more doctors consults.
They're like dressed and ready to go.
They're dressed at 7 a.m. I'm bedside rounding.
So just
Mary's dressed.
Right.
She's ready to go. She's got her heart monitor off.
She's called her daughter 2 hours away, coming in. Yeah. It happens. So
like literally this week, were you there? And I'm like, you have many more hours, unfortunately. Like I'll call people and let them know that you're ready, but heart monitor remains, I think.
Communicate with families and hear them, meet them if you can safely, meet them where they're at.
No, for sure. So what about equipment overload? I mean, this is something that's intimidating for me. I will say, like, I walk in, especially like CVIC, and we'll touch on that next week too. Oh my gosh, all the drips, all the machines, the CRRT. How do you? I mean, I feel like you need 2 different people, like one for the patient and one for all the
machines. It can feel like that. I had an incident not long ago where I got a patient back that was on a device, and by the end of my shift had 10 IV pumps because of the IV pumps situation that we have.
Right.
Was on 10 different drips, had 10 IV pumps, and in a room. Had no space for all of that, and it was very, very overwhelming because most nurses, I haven't found many male nurses, but most female nurses like all of their lines to be straight. They like things to be orderly and labeled and know where things.
Well, that's another ICU thing versus ER. ER. Joe got red when we were talking about organization versus
I got in trouble was it last weekend or weekend before, because I was like,
it's like that.
I was in a code and I was like, responsible for giving meds, because that is my favorite thing.
Yes.
And I'd put in the IO, and like there wasn't a trash can close to me. I was having to hold this guy's leg up, and like I was like throwing my flushes on the floor. And I was like, our friend, the house manager, the little one with the curly hair, that one. Yeah. She was like giving me all kinds.
What if somebody would have slipped and fell on one of your friends, your coworkers? You didn't care.
I was trying to save this man's life.
You couldn't have said,
I'm not concerned about
trash can, please.
Speaking of trash can.
Oh, fair. That is my name.
We're going to say that. We were going to tell people. So my son, who
do you know about those?
I love dearly. He's not, this is completely off topic, by the way. But I'm glad you said trash can. So he got to meet Luke, my son did. I mean, he's met him a few times, but
Poor kid.
he did this all on his own. He's not quite 4. He'll be 4 soon, but he named Luke Garbage Can. Yeah. Isn't it though? It's very...
I just kind of want to know why. Like, did I eat a lot or...
Do you
He just...
lie?
But he didn't... But not in front of him. Like, he just called me... Oh, it was at dinner.
It was at dinner.
Oh.
So it's not only how much you eat, apparently it's the way you eat.
Oh,
Yeah.
Or I am literally just a garbage can because this was like pre-meal. We had salsa. All we had was salsa. Like, we hadn't even...
I mean, my son is definitely a country turd. He sounds just like me. He sounds like cornbread and soup.
I don't think country turd would be a word that I would use. But...
Okay, maybe that was me. I call him a country turd. But yeah, garbage can. Anyways, that was completely off topic. Okay.
Next.
Back on track. No. So yeah. So like we've covered a lot of. What do you want your tip for new grads or people transitioning into the ICU? Not even that have to be new grads, but you probably feel like a new grad if you go from other.
You feel like I think so.
God.
Go from like a med surg to an ICU.
If you're starting out of school, extern program,
Absolutely, they didn't have that.
try to get pulled because you couldn't go straight to the ICU.
Right. Very true.
But oh my gosh, extern program, capstone, in that area if possible. Be a PCA in that area or a tech, so you at least have like working relationships down. I cannot imagine trying to learn like all of this equipment and devices and then like trying to learn like policy and like who's who in the unit and like, who is my resource that I go to each shift, who speaks my language. So, like
Nobody speaks your language.
Well, but also like
Garbage
seeing that stuff before. I told you that. I swear we had like a whole day lecture on like an MRI machine or something. But then like when I was in the hospital and I saw it and I took everything out of my pocket and I filled up that checklist, like
You're like,
it was like a 10-minute process of like, yeah,
the same thing
with
to the refrigerator.
Did I tell you about the extension?
What? Oh, hair extension?
Do you know that they're clips?
I don't know.
Yeah,
Well, you can have them.
Girl's hair got sucked off and pulled over to the.
True?
Yes.
Oh.
Yes, they were telling me about it. I've heard this in the past 3 months. The girl specifically, not like, and they were like, yeah.
Well, I mean,
it's like metal,
like a patient
sucked right off. No, not a patient, a nurse.
Okay, back where I'm from, some people get shot with BB guns.
Oh, and it like pulls the BB out.
It might pull the BB out.
In my ear, like if I had like little hoops on them, they like start to suck towards the.
Well, I told you I used to wear a bag
Tubes.
on a lanyard.
Can you?
And like my lanyard was like kind of floating up in the air towards the thing.
Magnet.
And I was like, "Ooh, this is fun." And I mean, because it is kind of fun. I mean, it's very
until all of a sudden, I was like, until it like severs your neck. I mean, they've scared me with them. I mean, I don't know.
I mean, anybody going into ICU, get you back on track. Anybody going into ICU, just again, know, like you said, know who your resources are, know who your support people are, and ask.
I mean, and I think that knowing that like studying does not end with those classes you're taking, and it does not end with school.
Well, in most places too, you have to be a little bit flexible because you might have different preceptors depending on people's schedules or call-ins or whatever may happen. You might feel very, very close to one preceptor and comfortable and in a good place, and you might get thrown with somebody else. But that doesn't mean that you can't learn something from them. Like, don't get.
Oh my gosh, you learn.
You
learn like. I've been providing a bunch of feedback this week for people in Capstone, and it's like they're like, oh, I was with a different person, and I'm like, you might see something done a way as long as like the practice is correct,
right,
and the outcome is correct. If that process works better for you, this is where you pick and choose.
Well, so
we're not. Yeah,
if it's what not to do.
Very true.
Fair.
Very true.
Yeah.
Fair. Yeah.
I mean, you can learn from anyone. I mean, I have absolutely learned what not to do from time to time.
You haven't learned to not put IVs in the AC clearly.
Well, and I think understanding also, like,
Heads up with an ER
on that preceptor level, just because you've had someone for 16 weeks, and let's say their orientation's 24 weeks in the ICU as a new grad, whatever it is, you should still be going in the room with them at week 10, 15, 16. There's a reason. Tell me what you hear on this assessment.
Mm-hmm.
Like what are you doing? Why are you touching that? Like, asking those questions. I mean, it's not really till like the last week, this isn't a vacation for you. Like this is someone that you're going to be working with.
The thing that's going to be
you want to make sure that they're competent, and every single interaction is a learning moment. It's kind of hard to even impress that upon students because they're just going in there to discharge them, and I'm like, all the discharge education. Like, you don't think that's important to know? Like, get in there. Are they just going in there to do a quick assessment? It's like, well, what is it? Do you know what a quick assessment is?
Right.
Like, get this. Like, this is information that you want to like heed and value.
Well, I think that in the ICU, I mean, I think all orientation should be very hands-on, but I feel like in the ICU, it has to be probably the most intense orientation process. And we've said it before, and I hate to be, crass or a little tough, but it's being a preceptor, especially to ICU, especially to a new grad, is not the opportunity to sit on your ass.
Not at all.
It's not.
Not at all.
Well,
that doesn't benefit
they have
anybody.
a lot to learn.
Doesn't benefit.
You have a lot to teach, and it's a lot of responsibility. And whenever you take it on, you got to be ready to get you got to put the work in. So
yeah, and you have to know how to talk to people because, like, again, they don't know what they don't know, so you can't.
They don't even know what questions to ask.
Right. They don't even know.
There needs to be somebody in there for them to ask questions.
Exactly. Yeah. But it doesn't, you put your patient in danger. You put that nurse doesn't feel competent when, they're just flying by the seat of their pants.
Yeah. So, utilize all the resources to learn. But yeah. So, I looked at, tips for new grads.
Mm-hmm.
So, I came up with, study your meds and drips. I think going into the ICU, especially as a new grad or anyone transitioning to the ICU, you are going to have a whole new set of meds to learn and understand. And titration is a big...
Quickly you can titrate in while we're waiting 3 minutes before we titrate again, or 30 minutes before we titrate again. And
quite frankly, and every single drug has a different policy and procedure for it. Now, I will say this, use your resources because there are some amazing badge buddies. They are usually specific to where you work.
Mm-hmm.
So don't just go get one or put one off the internet.
They're going to have classes, but you need to I would still suggest a deep dive and asking questions about those medications regularly, and really kind of like understanding how they're working in the body, because like when they explain like the pump, so like when we're talking about pressors, and it's like I'm going up on my pressor, I'm trying to get this map of 65, and well, like, if somebody doesn't have volume, so, like that critical thinking component, but also like what is happening? Well, I'm clamping down, and like my blood pressure is not going up, so like, oh, my CVP is like 0, right? So understanding that, like, if I clamp down and nothing's there, I've got a liver patient and all their fluid happens to be outside of their vasculature right now. Let's pull it in with some albumin or whatever. So, critical thinking, but also like, understanding that, meds work under certain conditions, such as.
And if you don't know what your med does, please don't give it
until you know.
Yeah.
Somebody tells you.
Yeah. But find out first. Yeah.
Hopefully it's in your orientation.
Whenever you're like looking around the room for an adult and you realize that
you're the adult.
Yeah.
Yeah.
We actually have.
I'm always the adult.
We have gotten to that point in our lives where, well, Luke's not, but we are the
Wheezy.
I'm really the adult.
Yeah.
Older.
Oh, you are.
So if I wrapping up, I have one question for you, Norma. Do you have any superstitions, nursing
I
superstitions?
thought you were going to say superpowers.
I have so many superpowers. No, superstition.
Occasions.
I mean, like every other nurse, you don't ever use the Q word. You don't ever use the quiet word when you're having a good shift. We used to, when I first started, if we would have somebody pass, we would have little windows at the bottom. You couldn't have that anymore because people were trying to climb out of them. But you would open it to let their soul soul leave the buildings here.
We could adapt.
Hospital wasn't haunted. Some people flush the toilet. I've heard that. Oh, somebody dies. I'm like, I don't know that where my spirit to go. But
okay.
Oh,
All right.
yeah.
Just still talking to him. I told you that.
Do you have any superstitions?
I don't think any.
You don't have any? I think
Really?
they come in threes. Deaths come in threes.
yeah. Yeah. I did
It's like,
during COVID. I had my worst night. We had 4 codes and they all passed, and I was done by the 4. And like in a couple hours span. I mean, I lost other people during COVID.
I signed provisionals now. If I sign 3 provisionals in a day, I'm like, I'm done.
Done. Yeah.
You can save them for night shift.
There is a certain person that if I work with, I know it's going to be a difficult night.
Oh, is it me?
Is that a
I think it's you. You're the problem.
Yeah.
It's only like when we're paired together, like we're finding weird stuff. Our energies don't match up correctly.
Maybe that's why we never win at bingo when you come with us. It is you.
It's you.
Okay, you won $2.
No.
You also don't play pool taps without me.
Not
You all got.
last night and I still lost. Well, we won $2. That's spent on more pool tabs and lost that. So yeah, no.
Your all's relationship is a whole different.
But you didn't win at bingo, right?
The podcast.
Oh, did you win at bingo?
No.
Yeah, there was no winning at bingo. I wasn't there. You didn't win at bingo. So what's the?
Maybe so. The person we were with was there.
We're just trying to make you the problem.
Maybe I spent too much time with me and it rubbed off on me.
Yeah.
All right.
That's a suspicion, or what did we just say? That's a
What did my gut say? I'm not.
He
a little stitches.
He only speaks one language and he still can't get it right.
Yeah. Here.
So thank you, Norma.
Thank you for having me. This was fun.
Yeah, I love it.
And thank you for having me. I had a lot of fun.
Yeah, we've enjoyed it. So next week we're going to have our CVICU friend is coming on, and her name is Laura Zapam.
Oh, that's a good one.
Oh my gosh.
Yeah. That's what she chose, man.
Laura Zapam.
I
Laura
like
Zapam.
it.
I like it.
I'll be honest with you. Somebody on here is going to go by Lucy Goosey soon, okay? Because that's what ChatGPT came up with her for, or Misty D. Meaner. What do you think about that?
Oh my gosh.
I know. It's funny. You're laughing. Okay. So yeah, this is just the beginning of our ICU series. We're going to be diving into some more. We've lined up CVICU, like I said, for next week. Already talking to somebody about coming on for trauma ICU. And we have someone that we want to ask for medical ICU. So we're reaching out. Surgical ICU and neuro ICU. If you are of that specialty and you want to be our guest, please reach out to me through our socials or on Code Brew Podcast at gmail.com. And I would love to talk to you about it. And we're having a good time with this. I'm excited about this CVIC episode next.
Yeah, I'm interested to hear what that person has to say.
It's gonna be fun
Too.
I don't
yeah.
know. Well, he works CVIC. I know it's CVIC.
So tune with us next time. Last plug for the merch store. Visit us at codebrewpodcast.myshopify.com for all your Code Brew gear. And like always, stay caffeinated, stay curious, and we'll see you next time on Code Brew.
Bye.
Bye.